delighted to introduce Martin Orton, who's Senior Programme Manager from the Professional Standards Record Body, and Andrew Sharpe, who's Advanced Podiatrist from Northern Alliance Care Alliance NHS Foundation Trust. I'm going to be talking to you about the Wound Care Information Record Standard. Please don't be put off by that title, because this is really interesting and really important in terms of data and how we collect data and coding, etc., etc. Hopefully I've got the gist there, Martin. We've had conversations before, so I'm going to hand over to you and stop waffling. Okay, thanks very much.
Thank you very much, Sarah. Good afternoon, everybody. As Sarah introduced, Martin Orton from the Professional Record Standards Body, CDM Programme Manager, and I led our work to develop the Wound Care Information Record Standard. Andrew was one of our clinical leads on the work, and hopefully he'll be joining us very shortly, and we'll share the presentation. So first of all, many of you probably haven't heard of the PRSB, the Professional Record Standards Body. So who are we? We're an independent, not-for-profit community interest company established by the Department of Health in about 2013, with the purpose of developing and supporting the adoption of records in health and social care, and more specifically the structure and content of what's in records. We're UK-wide, we're a membership body, and we'll talk about the members shortly. And because of our membership, we're able to uniquely represent clinicians, social care, and people in the work that we do. Our standards are very much to provide safe and effective record keeping to support care. We're pretty agile and flexible, and one of the key things is that we do try very hard to engage and consult with people who will be impacted by the standard, those who will be using it, the suppliers who will be involved as well. So it's really important to us. Although we're an independent not-for-profit company, we have a strategic partnership with NHS England. We're on a 4-year contract to supply services around record standards, which sort of makes us, if you like, part of the system. But we were deliberately set up to be independent rather than a part of the department or NHS England. In terms of our membership, growing all the time, currently have 88 members, but essentially it's all the Royal Colleges, organisations representing social care, both providers and local government. We have industry and system suppliers. We have the devolved administrations across the UK, regulators including CQC, and very importantly, patient and carer groups. We also have a partnership scheme with software suppliers. Very important that if we develop standards for the content of records, they're not going to be used if the suppliers don't build them into systems. So we have a partnership scheme working with suppliers to essentially work with them so they can understand policy directions, things that are coming, but also feed into our standards their feedback and things that work for them and don't. And there's a big range of suppliers we have now, from some quite small ones to some of the most of the major suppliers in England certainly, and across the UK. In terms of what we've done so far, so beginnings of our standards were actually transfers of care, and in particular discharge summaries, outpatient letters were some of the early ones that we did to define what should be in those, with the intention that they should become electronic, which they are now, and able to transfer information directly from hospitals to GP systems. We have a number of record standards, of which wound care is now one. Maternity, we're just in the process of revising. And one of the most important ones, the core information standard, which underpins the shared care records being developed across the 42 integrated care boards or services in England at the moment. We have several around personalised care. About Me has gained quite a lot of traction, is specifically for the information people want to share about themselves with professionals and others who are caring for them. and things like shared decision making, social prescribing. We have some standards that link into social care, and others that are there, and some implementation support toolkits as well. So that probably just gives you an idea of what we've got. Hopefully that makes sense, and do invite questions, although I seem to have just pick up the chat again somewhere. Make sure I've got the chat as well, so I can pick anything up that's there.
I can keep an eye on that for you as well, Martin, and give you the questions at the end if you want as well.
That would be very helpful, so I can focus on what we're talking about.
Yeah, that's fine.
Okay, I'll do a little bit of the introduction to the actual standard, and then Andrew will pick up and feed on. Andrew, are you with us now?
He is, Martin. Yeah, he's just
Excellent.
joined. There he is.
Okay, right. So what was the purpose? Essentially, we need to provide support to professionals with the information that they need about a person, the nature of the wound, previous care, to be able to share that information easily, mechanisms for making referrals, etc. And essentially also to support the embedding of best practice, well, evidence-based practice as defined by the National Wound Care Strategy Programme. It's also to support people. So we have people involved in developing the standard. Key things for them was that they felt understood and listened to, that their preferences were part of what was being considered, ideally allowing them to actually see the record and how do they feed in things they're doing for self-care, and making sure their healthcare is joined up, i.e. understanding their information can be shared between different organisations. And lastly, if you've got standardised information that's coded, it can start to support better overall sort of operation delivery and things like population health as well. So what is it? The Wound Care Information Record Standard defines the content of what should go in a wound care record. It includes the actual data items that should be recorded, the value sets, i.e. the codes and terms which should be used where that's appropriate, or free text where that's most appropriate. It's consistent with the recommendations of the National Wound Care Strategy, and actually all the work was commissioned by the National Wound Care Strategy Programme, and we've worked with them since then. The scope covers assessment, diagnosis, treatment and ongoing care and prevention of wounds, and it covers the same areas as the National Wound Care Strategy Programme in terms of being lower limb, leg and foot wounds, pressure ulcers and surgical wound complications. It's UK-wide and for adults and children. In terms of how it's developed, I've already mentioned that it was commissioned by the National Wound Care Strategy Programme. It's evidence-based, so the first stage we did was research and evidence gathering, looking both nationally and internationally, what standards were out there, what ways did people work, what was considered good practice, and we used all that. We then worked with 2 clinical leads. So as I say, Andrew's here today. We also had a nurse specialist in tissue viability as well, and a person with lived experience to make sure, bring us all down to earth and make sure it was real for people. We then started to draft the standard and then developed it through extensive consultations with professionals and people. And since getting to a final version of the standard, it's been endorsed by the following key organisations, including, I'm very pleased to say, the Society of Tissue Viability. And just a few things on the expected benefits for people, knowing that it's supporting evidence-based practice, which should help them get better and faster healing. Treatment plans that are based on their preferences and the way in which what's important to them, and knowing that their information can be shared. And some of these are sort of common when you look at the benefits for professionals and organisations. Again, supporting best practice, most effective use of people's time, being able to share the information, supporting public health and other areas like that. And I'm sure the slides will be shared if I'm whizzing through these too quickly. We certainly are happy to share them afterwards. I'm now going to pass over to Andrew, who's going to talk more about how the actual standard works.
Thank you, Martin.
You're quite broken up, Andrew.
Hopefully you can all hear me okay. So I'll
terribly well, Andrew.
I'll get talking about.
Not hearing any of that, unfortunately.
Andrew, we're only getting
As
occasional
Martin
bits
said,
of it.
I'm a clinician by background. My name's Andrew. I'm a podiatrist. If I the connection, do you want me to, if I try and log back on, might that work?
Yeah.
Let me just try and come through a different
Yeah,
method.
I would try leaving and coming back in, Andrew.
Can you hear me any better now?
Yes, that is.
Yeah, that's better.
Can you hear me any better now?
Yeah, that's much better.
Okay, sorry about that. I'm having firewall issues with at this end. So my apologies. So yeah, I'm Andrew Sharpe. I'm a podiatrist. My role with the PRSB has been, as Martin has touched on, as a clinical specialist, because my background is predominantly in diabetic foot care and foot ulcer care. And that's where Emily came in really well as a tissue viability specialist, with that crossover of care for lower limb support, pressure ulcer, and then the surgical wounds that we talked about. So how we're working with the PRSB is we've had a look, as Martin suggested, through all the evidence and found the assessment and treatment that we use in practice. So can you progress the slide on for me there, Martin, please?
Yep.
So we're across 3 domains: wound assessment and treatment. And what we're going to present to you now is the sort of the typical scenario. So we all do a baseline assessment, and what we try to, so as we've talked about with the research gathering and the evidence gathering, it started as a very large project for the PRSB doing all the data collection, and then the discussion that as a clinical team that we gave is to talk about what's more kind of theoretical or research based evidence and what is used more mainstay in practice. So to give an example of that, if you think about pressure ulcer assessments as an example, there's many different, I think there's something like 13 different pressure ulcer assessments, but some are more theoretical and have evolved, and sort of most common practice now is leading towards something like purpose T. So that would be one type of example with that. There's again many for wound assessments, many that are not necessarily evidence-based, but are used quite frequently and commonly in practice. And so that's how we kind of work the process. So when we get our patient in, we start with our baseline assessment. An element of this is wound description. Alongside the National Wound Care Strategy and recognising the National Wound Care Strategy as a key stakeholder, it's getting the diagnosis and the cause of the wound. And this is a bit from work such as Julian Guest has highlighted that it is quite often underdone. And other relevant conditions or issues, comorbidities, for example, that go alongside it. Our wound assessment and our observations, what's essential, what should be done, what could be done. And this will be, so the difficulty with this is to try and write a standard across 3 different domains of pressure ulcer, lower limb, and surgical, where some assessments in one would not necessarily apply to the same degree in the next. And hopefully, as I give you the example, that might make a little bit more sense. So we start with initial treatment, and we'll show you the treatment plan that developed from the baseline initial assessment. And for those of you that aren't aware of me, I would recommend having a look at the About Me program that's the PRSB run, which is really kind of an excellent kind of adjunct to everything we do in terms of making this holistic and patient-centered in its approach. So we use the personal care and support support plan record standard alongside this to look at the overall needs and goals. And the way you might set this out is to sort of suggest that a patient might be looking to, as an example, wound healing might not be their main priority. It might be their social element, or eliminating pain, or the social isolation element that comes with wound care. So it's about recognizing what's the patient's key objective, rather than just a clinician of thinking wound healing is the only goal. So that's where the personalised care and support plan comes in, with the overall need of the patient. And additional support then from the medical treatment details, and a contingency or escalation plans often written into these if things are starting to get worse. So the idea is that we don't nationally write in a standardised way, although we're probably all capturing there or thereabouts the same information, but it's quite interesting to know there is no minimum standard element. So the supported self-care section as well enables the recording of any self-care the person with a wound may do, and this has been, certainly since COVID, an element that has grown and becoming more common and informative practice. So you're okay to move the slide on there, Martin? So the implementation is not necessarily for individual clinicians. It comes across kind of the IT system suppliers to consider. So if you think about, as we move into a digital area of, as we go through a digital revolution, as more wound care becomes digitized, if you will, and using platforms from private companies or NHS organizations. So this, and this has been, like Martin has talked about, done through engagement with stakeholders, and they're well aware and have had chance to comment and consider this. Interestingly, again, I think most of what we do is not unique. It's just bringing it all together because it's stuff we all know. It's about the care professionals of expectation as well. So care professionals need to be aware of the standard. It's not necessarily about a complete and in-depth understanding. It's about comprehension of what can and may be done in that respect. And we should be reassured their systems implemented and operates in accordance with the information standard. So if we can skip on there, please, Martin. So now we'll talk about a leg ulcer patient example that we used when developing this. So this is Janice, 65-year-old lady, type 2 diabetes and a leg ulcer. The ulcer was a trauma wound, not healing, and it became a leg ulcer within the time frame. Janice was bandaging it herself to see the practice nurse who's assessed the wound and planned the treatment. She's got a diabetes care plan as well, which is supported with a personalised care and support plan, and it's updated to cover all of her health needs now. So the example shows the information that was recorded at the first appointment with the practice nurse, which is on the next slide in a moment. And only the elements of the information which are recorded in this example is what we've used. We've not necessarily included, because if you go onto the website, the PRSB website, these examples are available, and it's quite in depth as an example. So if we can progress that there, please, Martin. So on our wound assessment and treatment, and again, like I've mentioned, none of this is probably new knowledge for you guys. It's just about bringing together of information to say this is what is recognised as an evidence-based minimum standard, or not even necessarily minimum standard, as an ideal standard. So contact details of professionals, the problem that the patient's presenting with. We're looking within the wound care, the National Wound Care Strategy, with a leg ulcer for a diagnosis within 2 weeks. Within diabetic foot world, it's usually within 1 working day. And we talk about onset date and anatomical location. And different providers will have different ways of doing this. It might be body maps. It might be, like we see here, a typed descriptive of where it is on the patient. But interestingly, it's making sure we get the laterality, the body site, the anatomical site, and the type of wound. So it's a trauma wound, not healing, and we've diagnosed as a venous leg ulcer because of the initial assessment we've done with this lady. So we've got wound length and depth, You may be aware the wound elements that get brought in are things like time, where we look at the tissue type, whether there's infection, which is on the clinical observation side, the moisture levels, what the edge of the wound is doing, and what the skin colour. With infection, we look at the inflammation in the surrounding area as well. And the ideal is to capture some wound imaging, and there is some National Wound Care Strategy guidelines on how to capture the best type of wound image to get sort of a comparable photos between person to person when they're taking them. So the wound's got a local infection and an AB score of 0.9, so we're happy it's a venous leg ulcer at this point. We talk about pain scores, when it occurs, frequency of occurrence, and the signs and symptoms of infection. And this can be done alongside many different, or has been done alongside many different tools for gauging and measuring. So stuff like the Infectious Disease Society of America, IDSA guidelines are brought in to support all this. Exudate levels will tie in with what's the International Wound Infection Institute, and the overt and covert signs of infection ties in with that. So like I say, it's all tried to be as evidence-based as possible. Where possible, there's coding behind each of these. So it can be kind of from a top level, system level, you can see at what type of numbers and figures you're getting in that respect. So we look at the Dopplers, palpation and sounds, as well as our pressures, 3Ps, swelling within it, temperature, other observations of venous disease, and the personal observations as well. So if we can move that on there, please, Martin. We talk about previous treatments and current treatments. So this is initially what wound care products we're using: 4-layer bandaging, medication trade names if being used, such as medicaments, the type of wound care products. So in this instance, we're talking dressing, what procedures are being done with debridement, cleansing, etc. And then the plan and required actions, next steps as well. So we're following a personalised care and support plan. This might be a point of escalation where you recognise that we've got a delay in the wound healing or it needs escalating, and that might be the following actions, or you might have liaised with a colleague and discuss something specifically. So it's about capturing that type of information as well. And what are the risks for the delayed healing for these patients? So in this instance, we're talking local infection of the ulcer. So if you move that on there for me, please, Martin. So our wound treatment plan then is creating our personal care and support plan. Janice has a personal care and support plan. Easier done than said. And it's about what matters to the patient. So like I said at the beginning, often as a clinician, we think it's about healing the ulceration, but in this point, it might be the patient is really concerned about the level of pain, about the social isolation because of a smell, or it could be any number of things that you bring into this. It's about what is the most important thing for that individual. So the key things here is she wants to heal it, she wants to recover her mobility, and she wants to get back to her outdoor activity or out of the house activities that she enjoys. We know, so from a care and support plan where we take a more holistic approach and bringing in the about me principles, this lady's a confident and outgoing person, and it's really key that we help recover her mobility through helping heal the wound and providing a wound treatment plan and pain management plan. Talk to her about the things that she can do herself to support its self-management, pain management, leg elevation and physical activity, as well as a balanced diet. So if we can move that on there, please, Martin. And then the additional support plan. So depending which individual is filling this out, practice nurse might then pass it to supported self-care. It might be a community nurse or a podiatrist who escalates into a vascular situation, or specialist tissue viability team. And it might be that you don't necessarily need to see on a weekly basis, but you see on a monthly basis. So your schedule of assessment comes in here as to what your plan is and what the next steps are. So we're going for a dressing change 2 times a week. She'll have full assessments every month. and continuous review weekly once the infection's under control. Cleaning and debridements are primary aim, is part of our wound prep. We're treating topically with antimicrobial, 4-layer bandaging, and pain management as well. It may be that we are using antibiotics, at which point we'd flag that up as well. And our triggers, when to escalate, this could be something you agree as part of your MDT or as part of your specialist nursing services or specialist clinical services, as how and to when to escalate. So we're looking for them trigger factors of whether pain's not being managed, whether the wound's not improving, whether odours becoming offensive and what that means, whether it's infection or it's just an issue with the dressing type or dressing frequency, infection spreading. And then we also become aware of national guidelines like the pain ladder, might be part and parcel of our plan. The trigger for a tissue viability nurse referral as per your local pathways could be brought in there, and just monitoring the infection status as well. Who should be contacted and early warning signs, and this is information that can be shared then with the patient. So if we can progress that, please, Martin. So like I say, the PRSB website is a great link for this. Full details of the standard. And I'm right in saying the examples are either there or they're coming very, very shortly. So please have a look at the PRSB website when you get the opportunity. So if we move that, am I right in thinking that's the last slide there, Martin?
That is. That's the last one, Andrew. Thank you very much. And yeah, any questions? I hope that's been helpful.
Thanks both. That was really interesting. There's no questions at the moment, but I think, you know, it would be interesting to know from those that are out there, our attendees, you know, whether they're aware of the PRSB. I know that when we first got involved and looked at it, Martin, you know, that, you know, we obviously had to then realise that this is fed into the electronic patient record system that is used, and you demonstrated on a slide that there are many, and it's really helpful having seen this presentation and how you know, Andrew, you sort of set it out in the care planning part, and I think, yeah, it isn't anything new, but this is the standard that's expected, isn't it? And I suppose it's making sure that your digital systems capture that correctly so that the right evidence-based care is being delivered. Lynn mentions here that it's got similarities to the Sequin audit tool, which I suppose there will be that connection because that's what's expected, isn't it?
So it's worth saying we work very closely with the National Wound Care Strategy. We're a separate entity to the National Wound Care Strategy as we worked, but we did work very closely, and a lot of the clinicians involved or people who have sort of clinical backgrounds are very much the guys who are also involved in things like the wound care sequence. So none of this has been written in isolation from anything else that's already in existence. It's hopefully there to kind of butterfly or kind of augment into existing systems in quite a seamless way. There might be a couple of elements, and I think certainly from our clinical practice point of view, we cover a lot of these boxes, but not necessarily all. And I would imagine that is true of most, that you cover the majority, but not necessarily all these elements. And this could just be a way of supporting you moving forward, whether you go to a new EPR system or you start to have engagement with wound technologies that will slowly be becoming more and more common practice. And like I said, we have had conversations with the National Wound Care Strategy approved guys who are delivering the electronic record, the digital platforms. That's the word I'm looking for. Sorry, the digital platforms of wound care as well. So, like I say, hopefully it's nothing new. It's things that you are already
it's
doing.
pulling it all together, isn't it?
Exactly,
so it's
and
there in one place,
was the
really.
intention, really.
Yeah,
exactly, yeah.
And I think you did mention it earlier, but there's a question here around how will it work if we start to use digital wound assessment apps? And I noticed that you did have that displayed on a slide, I think like Healthy IO particularly. It will work within that?
He should do, yeah. These are guys engaging with us. Martin can probably tell you a little bit more about that element.
We've certainly engaged with them. We've finished our current sort of contract and funding area, but it's if they implement the standard and others do, then it should record information according to the standard, and that information should be shareable between apps and record systems accordingly. The thing that's difficult, I guess, for us is that there are many system suppliers out there doing these things. We don't have any immediate ability to go and make them do anything, but we did engage with them and we have talked to them, and certainly they all seem to be happy and in favour with the standard. So hopefully some of them are getting on and organising it. We certainly had discussions with the likes of Healthy IO and others around the standard, and we've also talked to some of them. The PRSB offers a conformance assessment capability, and we've talked to some of them about whether when they've got the standard implemented, would they like to come to us so we can give them a quality mark for conforming with the standard. So that's something to look out for later if people are looking at changing suppliers for their wound care systems or bringing in new systems. It's worth looking and or talking to us about whether or not those suppliers are conformant with the standard.
Someone's asked here about templates for wound documenting forms available, are there? But I suppose I'm not quite sure, Abigail, whether you mean sort of templates if it's like hard copies, paper versions, because I think we're very much moving, aren't we, into a digital world where a lot of these assessments should be undertaken digitally. Are you talking about maybe templates that can be downloaded and printed off to document, or maybe you could just put a comment about that? But I suppose in itself it's providing a template framework, isn't it, for everything that should be recorded?
I think we're providing what's behind it, and we would say that it's up to the system suppliers to provide the templates and so on that they think is appropriate. But the intention is they should meet with the standard, which then means you can share things between systems as well.
Okay,
so it might prompt them to make it might be that they're doing quite a lot of what we've got, but they missed a few bit. There are a few bits they haven't got in their systems, and maybe they need to add those, and they might need to just update their templates to include something a bit new or different, or to be more specific about the coding that they're allowing people to use and things like that.
Oh, got it. Yeah. Okay.
So it's the balance between what we define in a standard, but then enabling the suppliers to then implement it. And we don't want to restrict their ability to make it easy for people. And what we've not shown in the examples, but clearly the contacts with professionals, information such as the date and time of appointments, clearly you'd expect the system to automatically enter that according to who who's the professional that's using it, and they know it's this appointment. So there's as much as possible should be either automatically entered or on easy selection systems, etc. But that's up to the system suppliers.
Okay. There's a question here around wound pictures, so digital images, and I know that's in the standard that should be undertaken. Any sort of standards on how often they should be done and how to keep them? Is that all down to the provider of that sort of that record?
Yeah, so it will be what cloud-based platforms you'll have within your locality. There is some guidance on how and lighting and things within the National Wound Care Strategy website.
Yeah.
But in terms of where to store and things, that becomes a digital, like your IT departments need to ensure that you, depending which device you're using to take them and how, because it's that digital safe storage of uploading into your systems. It's sorry, Martin, go.
No, it's all right. I interrupted. Carry on.
It's not an easy answer, because whenever you look to do these type of things, there's a lot of detail to consider, and that becomes a lot of the barrier actually with why we're probably not more widespread with our digital platforms. This element of governance that sits there to make sure that you've got a robust and safe system, because filing cabinets do a great job and we know where they are and you know when you've been broken into, whereas a digital world becomes a lot more murky sometimes. So that's why it's not an easy and quick answer, unfortunately.
Okay.
And we at the PRSB don't provide guidance on how long you should keep things. The Institute of Health Records and Information Management, I think they provide guidance, and there's other national guidance from people who we advise on our role is around the content of what's in there, the how long you keep it, and then that comes down to, I would imagine, local providers with their own policies on how long they keep things, which obviously varies. GP records are lifetime, aren't they? Hospital records have a time limit on them, and then they delete. It's variable.
Yeah, absolutely. And yes, I suppose just goes back to it's linking in with your local policy around that, isn't it? Thank you so much. That was really interesting, and hopefully there's a lot of people on the call today that might not even been aware, so hopefully you'll take a lot back from that session just now. So thanks very much for coming to talk to us, you two. Really appreciate it.